Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
Well, hello, folks. Welcome back to the Metabolic MD / CGM Doctor with Dr. Paul Kolodzik. Dr. Paul, hello.
Hello, Terry.
And we are heading into St. Patrick's Day. My last name is O'Brien, and I want to wish everybody out there a happy St. Patrick's Day. What nationality is Kolodzik, by the way?
So, first of all, it was shortened. It used to be Kolodzik.
No, it did not.
No, it did not.
Well, is it from Germany?
It's Polish. It's Polish, but it's actually on the border between Poland and Germany, and it kind of depended upon what century and what the conquest or the war was at the time.
Yeah.
Whether it was considered Polish or German, but basically Poland. The Danzig area of Poland is where my ancestors come from. But on the other side, I do have some Irish in me, Terry. So
I got 1,000 jokes I could reply to that one, but because we're keeping this clean, we're going to let that go.
Well, my maternal grandmother's maiden name was Clancy.
Oh, that's a good one.
So
yeah,
I do have some Irish in me.
All right. Well, that's not why we're here. We're here to talk about GLP-1 medicine, which is extremely popular, still is extremely popular and getting more so, and Medicare.
Right.
And how those two might work together and how they don't work together.
Right.
So what's the gig with, I just went on Medicare last month, started in February.
Yeah.
What's the gig with people getting GLP-1 medicines if I'm on Medicare?
So first of all, just so everybody understands what we're talking about Medicare, which is the health insurance for people that are 65 years or older.
Yep.
There are younger people that are on disability that are also on Medicare as well, but the majority are people that are 65 years of age or older. And as you know, there's a variety of flavors of different types of Medicare. There's straight up Medicare, in all these different parts, A and B and Part D, which is the drug portion of Medicare.
I got them all. I bought them all.
Yeah. But then there's, if you don't want to do only straight Medicare, you can do Medicare plus what's called a supplemental insurance program.
Yeah, I think I can't remember what the hell. I have a supplemental card.
Yeah, so that'll give you extra coverage. You got to pay extra for that.
Yeah.
Yeah, and then other people offer something called Medicare Advantage, which is kind of a whole in nuts to bolts coverage, which is provided through a contracted insurance company, like, for example, United Healthcare.
That's what I have. I said, I want the Cadillac coverage.
Yeah.
So would I be covered for GLP-1?
Well, let's talk about that. It depends. The
way,
answer is it depends.
Well, what? So just for the folks listening, because I get confused about this all the time, Medicare is one thing.
Yeah.
What's Medicaid?
Medicaid is for generally low-income people that are under 65.
And is GLP-1 available in Medicaid?
Generally not. Now, that's a state-by-state decision.
Yeah.
And for people on Medicaid, there was a few states, like a year and a half ago, that did cover GLP-1s. And, of course, we're talking about Wegovy and Zepbound, which are the two GLP-1s for weight loss.
Sure, good stuff. Yeah.
But actually, some Medicaid programs in those states saw what it was doing to their budget.
Because of the cost.
Because of the cost, and they reversed that. So I don't know now if, quite honestly, there's any Medicaid, any states' Medicaid programs that cover GLP-1s, but I know that it's not covered widely.
Okay, so let's focus today on Medicare.
Yeah.
Go ahead.
Let's first talk about a conceptual issue. So people look at this and they say, well, why wouldn't we want everybody to get these medications? Because they're going to decrease obesity and decrease the risk of all these other very expensive medical conditions, like, help prevent diabetes, help prevent kidney failure, help prevent prevent strokes, help prevent heart attacks, prevent fatty liver disease. Why isn't it a no-brainer to just go ahead and cover these medications for everybody? And the answer really is this. It's kind of a chicken or egg question. In that I think, long term, that is a good idea for appropriate people, as long as people are making lifestyle changes and doing the other things that we always talk about here. But it's an investment issue. It's like there isn't the money up front to do that. There's not enough money in the system to pay $12,000 a year for the 60% of Americans that are overweight to cover that. So it's not that it's a bad idea to appropriately, for people that meet criteria, consider these medications, but there just isn't the resources in the system. And of course, with Medicare in particular, you hear almost weekly now about the budgetary issues facing Social Security.
Oh, sure. Yeah, they're going through
Medicare.
cuts as we speak,
Yeah.
right?
And so to add, a lot more costs to these programs just isn't in the cards right now.
Well, okay. Well, I'm just going to play devil's advocate here for a second. I truly believe GLP-1 medicines could be such a great change for society, right? It's a natural substance. That's GLP-1 is a hormone, right? That naturally it's in your body.
Yeah,
and helps
the drugs
digest.
are a mimic of
Right.
those hormones. Yeah.
So it's not like some miracle crazy thing you're sticking in. You're basically sticking in some natural substance that's been there for a while.
Well, it's synthetic. It's made
Sure.
synthetically.
But so is
yeah.
insulin, isn't it?
Yes.
Okay. So if that's true, and it could solve a lot of issues we have with budgets, because if you can get people healthier, we're not spending the money. Why can't the government step in and say, listen?
Yeah, Terry, we were talking about this before we started this podcast.
Yeah.
And we were running some numbers. It's because even as much as the federal government dismisses billions of dollars in expense in many areas, and wastes a lot of money, there's just not an extra whatever it would be, $400 billion around right now to cover this for Medicare people.
I mean, but couldn't they say, hey, we're not going to pay the high price, we're going to pay a much lower price, and the manufacturers would make it volume?
Yeah, there's negotiation now for the first time in the last few years where Medicare is negotiating with drug companies to lower the costs. There's a lot of lawsuits related to that going on. I don't know exactly where it is. Sure. But you're right. But the bottom line is, I don't want to be a downer, but we're already $36 trillion in debt as a country.
Right.
Those projections, I think over the next 10 years get us to, $55 trillion. Not sustainable.
It's not.
And there's just not a lot of extra money in the system to go ahead and do this. So
we're roughly a
Medicare has
$20 trillion
restrictions.
GP, right? The country makes basically $20 trillion in revenue overall. But if we're $50 trillion, we cannot afford that kind of...
Yeah, and I'm not saying it's a bad thing. The other thing, though, I think I'm hesitant about is just prescribing people medicines. I think there should be program requirements associated with the use of these medications.
What does that mean? I don't understand.
Well, I just think you have to, I think you should have to be, this is just my opinion, whether it's private insurance or otherwise, that you should have to be involved in some type of program that addresses the things I've addressed in my practice for the last 7 years, which is, some kind of appropriate diet, some kind of a workout plan.
Right.
I don't think, as people are finding out, a lot of times people are just being prescribed these medicines, no strings attached, no support, no program.
Right.
And they become dependent on the medications for life. And, some people say, well, diabetics are dependent upon insulin for life, or people with high blood pressure are dependent upon high blood pressure medicine for life. Why is that such a big deal? I just, I guess I'm a purist, and I think that people should have to have some skin in the game in terms of lowering their risk factors. And there's other benefits to those lifestyle changes as well. So I think providing the medicine for certain people can be a good thing, but I think it should be in the context of a comprehensive program.
So do we know where Robert Kennedy stands on GLP-1s? Have we ever heard?
I have not heard. Yeah,
that'd be interesting to find out.
But I can certainly tell you that he's lifestyle guy in terms of
absolutely.
wanting to decrease processed foods and the risks associated with that. And did you see that video of him pumping iron?
I saw him push-ups. How old is he? He's older than you, isn't he?
Yeah, I think he's 68 or 70 or
I mean,
something.
he looks like he's probably
Yeah.
mid-40s, easy. The guy looks incredible.
Well, I don't think he looks quite that.
He looks good.
Yeah.
I
So
mean,
at any rate, he would emphasize lifestyle changes.
not that I'm a mega guy at all, right? But I do agree that making America healthy again is a good thing.
Yeah.
Which could start with kids' lunches and crap like that. But we're off topic from Medicare.
Yeah, I'm going to be off topic for just a little bit
Go
more.
ahead.
So there's all this discussion to make America healthy again, and red dyes and different food additives, and I agree with all of that. But I'll tell you the low hanging fruit, 85% of the problem is excessive carbohydrates. So if we just reverse the food pyramid and focused on lower carb diets like we had before the food pyramid came in, like we had when back in the 50s and 60s when people were not overweight and obese, if we just lessened our carb intake, and I would put, I don't want to digress too much, but usually with processed foods there's carbs and there's seed oils. If we would just lower our carb intake, lower our seed oil intake, I think that is literally 85% of the battle.
Really? So remind me again, at the top of the pyramid today is what? Is it proteins? Do you remember? I can't remember.
The fats.
Fats.
The
Fats are the very top.
It's upside down.
So
the
you're
pyramid
saying
is upside
move
down.
the fats and proteins, everything at the bottom, the wider base, so there's more of it.
Yeah.
And then put carbs at the very top.
Yeah.
Okay.
With sugar at the tippy top.
Tippy top.
Okay, so we digressed.
We
here.
did. So back to
Yeah.
Medicare. If I'm on Medicare, and I am, and I need a GLP-1, and I'm not a diabetic, can I get it?
So these are the criteria right now, and this is evolving, but there are limited number of conditions where a GLP-1 can be prescribed, that is Wegovy or Zepbound, for a patient that is on Medicare that is not diabetic. So if you're diabetic, it generally is going to be covered.
Yep.
The other new indications that have come out recently, and this is it's different for Wegovy than Zepbound, but in general, these are the rules. If you have a previous cardiac event, like a heart attack or congestive heart failure,
right,
and you're obese, then there can be an indication for that it can be prescribed and covered. You're going to have to get, all of these conditions will require a prior authorization by a physician, which means the doctor has to testify that this person, of course, is eligible for a GLP-1 because they are obese, they meet that criteria, and they meet the fact that they have a cardiovascular process.
Oh, you mean testified? You just scared me a little bit there. They don't have to go in front of a court. They're just filling out a form.
But you have to
clicking
fill out a
button.
form and sign it.
They have to sign it.
Yeah, I mean,
is it all
it's
electronic?
It's
part of
yeah.
Okay.
It's fraud if you.
So you're saying this guy's overweight. He makes conditions. He deserves to be on it.
Yeah.
Okay.
Yeah. So a previous cardiac event, new one came out just in the last 6 months. Two other new ones, which is kidney failure. Okay, if you're overweight and you have kidney failure, then there can be coverage for that. And then the third one, which just came out actually within the last probably couple months, is obstructive sleep apnea.
What?
Yeah, people that have sleep apnea
wear the mask.
Wear the mask. Yeah.
So if those folks wear a mask, they can get this. They can get a GLP-1. Most likely.
If they meet BMI criteria, if they meet the other obesity criteria.
Oh, wow. That's crazy. Okay.
Yeah.
So I know some people, they may not know that.
Yeah, those are the three indications. And so, they're so, but that's not the vast majority of people. The vast majority of people that are obese and overweight and over 65 don't have those conditions.
Okay.
Yeah.
So is there anything else that would let somebody on Medicare get access to GLP-1s at a lower price that you know of? Is there?
So the approach always has been but we can go ahead and talk about that. So basically the cost for these medicines, and actually we're predicating this whole discussion on the cost, which is
Sure.
$1,000 to $1,200 a month if you don't have insurance
List
coverage
price,
for
right.
it. Yeah.
Yeah.
There is a discount program for lower doses for Zepbound, okay, which is one of these two products through the manufacturer, where you can go ahead and get that medication cheaper for the first 2 doses, which is the lower doses. There's a series of 4 or 5 different doses, but you can get a discount program for the first couple.
So there's
doses.
no single care card or those little things you sign up for?
I don't think they generally help with this. Yeah.
All right.
But in order to get that discount, rather than getting a pen, you receive a vial, and you have to draw it up like an insulin syringe and inject it.
Which is
not that big a deal.
No.
Yeah, you're right. We teach our people, and then to do that when needed. And then the third alternative is the compounded medications. In our case, we look at the semaglutide for that only. And those medications, though they're widely used and prescribed, are not FDA approved. But they're generally available at about a third the cost. So
semaglutide is equal to GLP-1. I just want to make sure. This is a confusing thing. Right?
Semaglutide is a GLP-1, but you got to be very careful. It is not labeled as a generic.
Yeah.
Okay, because only the FDA can label things as a generic.
Yep.
And it is not FDA approved. It's made in state license compounding pharmacies.
Okay.
So and for semaglutide only, we make that available. In fact, we have Medicare patients that can't access GLP-1s for weight loss for the reasons that we've discussed. So the compounded medicine is available at about a third the cost. But again, we always, the approaches begin with the end in mind. There has to be a program associated with these, for one reason, cost, because you want to get off these medications eventually. And of course, what we've been doing for years is low carb diet with the assistance of continuous glucose monitors, which can be very valuable, whether used just, intermittently or constantly, intermittent fasting.
Yeah.
And then strength training, because of course when you're on these medications, you're not only losing fat, you're losing muscle mass. So you got to be strength training and bumping your protein portion of your diet.
I will tell you, as a diabetic who exercises every day, I notice my blood sugar will drop significantly when I'm doing strength training. So 10, 15 minutes after I'm done strength training, my numbers go much lower than if I was just doing treadmill.
Yeah.
So that strength training has a lot to do with it.
Well, basically muscle mass is a sink, which means it's drawing in insulin and blood sugar.
Yeah.
So that's why, again, I feel strength training is, so important. And in fact, the regimen that I have for my patients is you got to do your cardiovascular training. We'll follow the American Heart Association guidelines. If you do that in a focused manner, you can get it done in 75 minutes a week, meeting your heart rate criteria. But, you should be spending 3 or 4 times that much every week on strength training. And think about it. So, you're asking for 5-ish hours a week, for a combination of cardiovascular fitness and strength training. And that should be doable for most people. I'm not dismissing, busy parents, have a job, all that, but this is important stuff.
What's funny is I recently got the rubber bands. I don't know what they call them.
I think
Strength
bands are great. Yeah,
they're fantastic.
Yeah.
It takes up no space at all. They're easy to use. You use them. It's a fantastic way of getting strength training in. And it doesn't take any. You don't have to go to the gym. You don't have to have dumbbells.
No,
these work great.
Yeah, they work great. They're transportable too for people. For people that travel. And I would say the majority, actually, of my patients that have not done strength training before. And again, I have a lot of older patients, Medicare patients, that we get on these programs. The way to start generally is with a set of bands, and I do like sometimes to have them just get a single set of lightweight barbells, for the women that have not lifted before.
Sure.
Maybe 5 or 10 pound barbells, dumbbells, which are the individual ones. And you can get a complete workout in with that.
All right, so let's go back to the Medicare thing because I want to make sure we hit everything we need to hit on this topic. So Medicare, only if you meet certain conditions, will pay for a GLP-1.
Correct.
And do you think in the future that'll change? We had this conversation before.
Yeah.
The likelihood is unlikely because of the cost would just cause Medicare to zoom out
I
of
think
control.
there's going to be this nibbling around the edges for additional conditions.
Yeah.
Okay. So just like they added previous cardiac event, kidney disease, sleep apnea, I think the next one on the list is fatty liver disease. Okay. But I think what'll happen is that it'll be recognized that the incidence in patients that are obese, that have these conditions, the risk of complications can be decreased. And so I think we're going to nibble around the edges. But in terms of a wholesale, you're just overweight and you're going to get a GLP-1, I don't think that's going to happen.
So the logic that we were talking about earlier was if people could get on a GLP-1 with a program, so I'm going to make sure I said program, their hospital visits would go down.
Yeah, long term.
Which would mean their cost over here go down, but this goes up. So it's kind of a balancing thing where.
Well, long term, I think if there was the money to invest, it would decrease. I mean, it would be a money saving move. Again, I'm not talking about putting GLP-1s in the water so everybody gets them. It's a selected group of people that are doing a program. I think long term that would decrease costs. End of life care, for example, related to people in ICUs and having strokes and heart attacks and kidney failure, et cetera, is very, very expensive.
Oh, it's totally expensive. Isn't that where most of the costs come from?
That is where
the last few months.
Yeah, a lot of the costs can go there.
What's the options? What do other countries do? You know?
For what?
Like the last few months, do they try to maintain you, and even if you're in a crappy bed?
Yeah, my experience is the United States is the most aggressive in trying to manage end of life care.
But is that a sorry to get off topic, but is that a philosophy? Is it a way to make money for the hospitals? What is it? What's causing that? Because
I think it has to do. I think those are pertinent facts. I think legal considerations enter into that, and we honor families' wishes. And a lot of families, it's like do everything.
Yeah.
I mean, I've kind of been involved in some situations where sometimes family members. This is completely digress, but I'll just tell you it happens, is that family members that maybe have not been real involved in a parent, having problems that have progressed, now want everything done. There's maybe a little bit of guilt associated with that.
Yeah.
So
But as a patient, right, I think they would like just to get the heck out of here.
Different patients have different perspectives. I took care of a patient with esophageal cancer 2 days ago that was in pretty bad shape, but did not want a hospice referral, still wanted everything done.
He wanted to find.
Said he had stuff to do before he died, and he wanted to be able to address that. So I think the reason for our costs is that, we respect all that or consider all that to the extent that others countries don't. And let me give you an example. We provide dialysis to nearly all patients with kidney failure.
Sure.
In other countries, and I've heard this is particularly true in Great Britain, if you have kidney failure and you're above a certain age, which I think is late 60s, early 70s, the answer is we aren't going to provide you dialysis, or we're going to provide you dialysis for this limited period of time. So go home and start making your plans with your family.
Really?
Yeah. So they limit the care. Yeah.
That's crazy.
Yeah. It's just a different world here.
It is a different world. I
the
agree.
way we have evolved over time.
Yeah. Well.
Yeah.
So GLP-1s, we know they have a positive impact on society. They could have a positive impact on cost overall, but it takes this balancing act to get there.
It takes this long investment.
And you
period.
think over time things will change slightly and become more available for more people.
Yeah, and I think a lot of things will happen. I think Medicare will negotiate lower costs.
Right.
I think the number of indications will expand. But for right now, I mean, it's not going to change dramatically in the next few years.
All right. Well, we've got off topic quite a bit on this one, but there's 1,000 different paths we could go down if we wanted to. Anything else we want to let these folks know about GLP-1s and Medicare?
No, other than, again, I think if you're a Medicare recipient, first of all, look to those lifestyle changes and what can be done. A lot of information on my Metabolic MD's website and also the CGM doctor website. I think a good place to start is to get a continuous glucose monitor and see what's going on with your blood sugar, because blood sugar issues are the reason for the majority of obesity and being overweight in this country, with the problem called insulin resistance that we've talked about before. So I think that's where you start. And that's what I try and do with my patients. And then if you decide you want to dip your toe in the water of GLP-1s, and of course that's kind of my approach, which we've called microdosing, which is lower doses for limited periods of time. Then you need check on your eligibility if you have one of those other conditions. If you're Medicare Advantage, there's a chance there may be a program out there or two that would provide coverage. But then the other alternative is the compounded semaglutide, which we do with patients, that's available at about a third the cost.
All right. Well, again, this has been another I always love talking about this stuff because we could talk about different topics. We come from different sides of the aisle, so to speak. But we do meet in the middle when it comes to getting healthy, about getting younger folks healthy and less obesity.
Yes.
Okay. Hey, well, this has been the Metabolic MD. I'm Terry O'Brien, the producer. Thank you to Dr. Paul Kolodzik. He is the founder of CGM-Doctor and also MetabolicMDs.com. You can go check out all kinds of useful information on those sites. And we'll see y'all again real soon on the Metabolic MD /CGM Doctor.